now we're going to switch from talking about OR utilization and talking about Economics 101 for the Labor and Delivery Suite. Another title for this talk could be, what does a minute of operating room time cost? And oftentimes you'll be in the operating room and something will happen and it will prompt somebody in the operating room to say, boy, that wasted minute is going to cost us some big number. And so a question that comes up is, what does a minute of operating room time cost, whether it's in labor and delivery or in the main OR? And I think the answer to that question is, it depends. It depends, first of all, on what country you're in. And then it depends on whether you're talking about charges as they appear on the hospital bill that the patient gets once they get home, or a cost to the hospital of actually providing that care. Or it also depends on whether you're talking about fixed costs, which are the overhead costs, or variable costs, which are the supplies and drugs that we use. So it's a complicated answer to a simple question. We've talked about the disclosure. And in terms of learning points, I think this is such an obvious statement, but people that should know better still confuse the two terms. Costs and charges are not the same. Hospitals know exactly the charges on the hospital bill, but charges do not reflect the true cost of providing care. So you'll be at a meeting, you'll be talking about making the labor and delivery suite more efficient, and someone will say, what does it cost to do a cesarean at this hospital? Well, some people, when they hear that question, will think, what does it cost the hospital to have staff and equipment and supplies and a facility so that the cesarean can occur? Other people will say, well, what's the charge on the hospital bill? And so we need to get agreement about whether we're talking about costs or charges. And costs can be either divided into fixed costs, overhead, or variable costs, which typically are supplies. And I think when we go to work every morning, almost all of the cost of taking care of the patient is going to be a fixed cost because the people are there, the equipment's there. On the day of surgery, whether it's for a cesarean or any other kind of procedure, more than 90% of the cost is overhead because everyone is there and the equipment and facility is there. It turns out that it should come as no surprise that the costliest hospital day is the first one. So if you have a hospital length of stay after cesarean of 2 days, the first day is more expensive than the second day. And the longer the patient's in the hospital, the cost per day progressively decreases. And this becomes important because in efforts to reduce length of stay to save the system money, if you reduce the last day of the hospital stay, you're actually reducing the day that costs the hospital least. And if the hospital is getting paid a per diem for each day the patient's in the hospital, reducing the length of stay may actually hurt the hospital financially if you don't understand that that last day that's being reduced is actually the most inexpensive day to the hospital because the patient's almost ready to go home. Let's turn our attention to this simple question that occurs over and over again. What does a minute of OR time cost? Does anyone have any numbers? $43. Do I hear 50? Well, we have to decide whether we're talking about costs or charges. We have to decide what country you're in, what surgical procedure is being performed. So if you're doing a cesarean, the cost per minute is going to be quite different than if you're doing coronary artery bypass surgery or inguinal hernia repair. So depending on the type of case you're doing, the cost is going to be quite different. You look at the charges as they appear on the hospital bill, and then whether you're talking about fixed costs or variable costs. So it turns out that in the state of Pennsylvania, there's a state law that says that charges for hospital care have to be publicly available. So this is a hospital in Cleveland, I think it's the University Hospital, and if you go there, you can actually see what the charges for operating room time are. And they, at this particular hospital, divide OR time into 6 different levels. The first level, the per minute charge for operating room time is $64, and that goes all the way up to level 6, which is for a complicated case. It's going to be $128 per minute. Now this does not include a lot of other things that you might think should be included, including the charges for anesthesia drugs or supplies. This is, also does not include, obviously, the professional fees of the physicians in the operating room. So at this hospital, the cost is between the charge to the patient is between $64 and $128. Let's repeat this to make sure we're all on the same page. The amount of money that the hospital has to spend to buy supplies and to pay the staff to deliver medical care is the cost. What was shown on that website are the charges that the patient's going to get billed when they go home. And that's the amount of money the doctor or the hospital bills the insurance company for medical care. This is the same hospital, and these are the labor and delivery charges. What do they charge for a normal delivery? And at this hospital, it's $2,700. And that does not include lots of other things, such as if the OB does an ultrasound, that's $701. Fetal non-stress test is $533. And the charge to the patient, as it appears on the hospital bill, for an hour in the labor room before they go to the operating room is $320. So these numbers can add up pretty fast if the patient's in the hospital for an uncomplicated delivery. And oftentimes you'll see articles in the newspaper sort of lamenting how high these charges are. And part of the reason the charges are high is because different payers will pay different amounts of money for the care. So from a hospital point of view, you want to have high charges in case you get a patient from another country who's willing to pay cash, and you can collect a high value. Other payers reimburse the hospital based upon a discount as a percent of charges, so the higher the charges, the more money you get. The other important idea, besides figuring out the difference between the charge and the cost, is that it's very difficult for a hospital or labor delivery suite to really know what the cost of care is. So tomorrow, when you go to work and you ask someone, what does it really cost to provide an hour of operating time? The manager can find out what the charge on the hospital bill is, but they really probably have very little idea of what it actually costs. Now, the cost is going to be the sum of the people that are there and the equipment and supplies that are there. So I think one of the reasons, kind of a knee-jerk reaction to what does it cost, people will respond by looking at the charges, is because it's a lot easier to find that out. It's a number that's more accessible. Now, this is a different hospital in the East Coast, and these are the labor and delivery charges for different things. And the idea is if the public has access to these charges, they'll be able to make better decisions about where they get their care. The problem is that the charges may not reflect what the true cost of care is at the hospital. And so if you look at the relationship between costs and charges, it's not a direct relationship. It varies depending upon the item. The cost to charge ratios vary. So if you look at the relationship between what the hospital charges to do an amniocentesis and what the hospital believes the true cost of doing that procedure, it may be some number. If you look at the cost of the labor room and you compare that to the charge, that ratio will be different. So it's very difficult to tell at first glance what the relationship is. And so if a hospital makes decisions about allocating resources based upon charges, it's going to make bad decisions because the charges are not going to reflect the true cost of care. So this is an example of that. This is a hospital where they charge for anesthesia supplies and equipment a certain amount, and then they looked at the cost of providing those supplies and equipment. And as a fraction of the entire hospital stay, for this procedure, the charges for anesthesia were 9%, whereas if you actually looked at the true cost measured by accounting people, it was more like 5%. So a manager that looks at these data may have a warped sense of the true impact of, in this case, anesthesia supplies and equipment on the entire cost of the surgery. All of you know that costs can be divided into two types: fixed costs, which do not change relative to volume of activity. Those are typically thought of as overhead. And then the variable costs do change relative to volume of activity. And what are examples of fixed costs? Well, the hospital or the labor and delivery suite has a bunch of people that need to manage and administer the hospital. That's a big piece of it. Whether the patient, whether the hospital is full or not does not affect how many administrative people there are in the hospital that day. So as a result, that's an overhead cost. There's other things like equipment and IT and depreciation and housekeeping. So for any particular hospital, the cost of taking care of a patient on any given day, the majority are overhead costs. So when the hospital or the labor and delivery suite asks you as a physician or nurse to help reduce costs, you can work with them to reduce variable costs, but you can also ask them, what are you doing to reduce the overhead costs? And you can follow up by saying that, to take care of the patient tomorrow, the majority of the cost is going to be overhead, so what are we doing in that area? And ultimately, the impact of reducing the overhead is going to be greater than reducing the fixed costs. So what are things that a hospital can do to reduce overhead costs? Well, for example, if the housekeeping function can be outsourced, where it becomes a variable cost or the cost of the housekeeping is reduced because it's done by somebody else and not the hospital itself, then that may be a way to reduce fixed costs. Another crucial take-home message is that as doctors and nurses, we only affect variable costs. We are able to make decisions about drugs, supplies, whether an X-ray is ordered, whether a CBC is obtained, and whether blood is given. And those are important decisions, but only address variable costs of care, not the fixed costs. So if we're interested in better management of the labor and delivery suite, we should also think about how do we manage the overhead better. And this is an example at a particular hospital where we looked at the relationship between the cost of what was being done there relative to the charge. So for instance, in the blood bank, if $100, 73% of the cost of the hospital of providing blood bank service was deemed to be a variable cost. And that's because every time we give a unit of blood, that's an incremental cost to the patient. And the more blood we give, the greater the cost in the blood bank. In contrast, in radiology, most of the machines are overhead costs. So whether we order one less CT scan or not will not affect the cost as much as in the blood bank because almost 70% of the cost of radiology is an overhead cost. So figuring out where your cost centers that are heavy on fixed costs versus variable costs will give you some idea of the relationship between variable costs and overhead costs. So let's get back to that question about OR costs and how much an OR time really does cost. We know that the charges can be north of $100 per minute, but what about the true cost? Well, I think you have to separate those into two elements. The first element is a basic rate costed according to how long the patient's in the operating room and includes supplies and labor common to all procedures. What does it cost to have an OR with the lights on, people in it, and basic equipment ready to go to do a very straightforward case? That's a certain cost. And then in addition to that, if you're doing a more complex case, what are the incremental costs? So we have to separate those two to really try to nail this number down a little bit. And this is another hospital which also provides patient prices, but again, these are operating room charges, not cost to the hospital providing care. And we know that the first hour of OR time costs the most because the bulk of the supplies, the surgical tray, and the bulk of support labor, room setup and picking instruments occur in the first part of the case. So just as reducing the length of stay from 3 days to 2 days after a surgical procedure may not have as big an impact on cost because the third day is the least expensive day of the hospital, reducing how long a case lasts may also not have as much of an impact in the cost of the procedure as you might think, partly because almost all the costs of doing the surgery that day are overhead costs and they've already been spent, and also because as the case goes on and on, unless there's a horrible complication, you need more stuff, is going to be less expensive than the first part of the case. So please keep in mind that the costliest hospital day is the first one. The cost per day progressively decreases such that the discharge day is the least costly day. And reducing the number of days the patient's in the hospital may not save the hospital as much money because eliminating the last day is the least costly day. And I think once you realize that such a big fraction of the cost of running a hospital is overhead, you realize why the CEO of any hospital is so worried and concerned about the patient census. Every day, I think every CEO of a hospital wants to know how many patients are in the hospital, because if the hospital is not full, that means there are lots fewer patients to spread the large cost of running a hospital. And that's why we get in these situations where the census is basically 100% every day, because the hospital can't afford not to be completely full. Because if the hospital is not completely full, then you have fewer patients to cover all of the overhead, which means that the cost per patient goes up. A couple other ideas that you may run into. One is contribution margin, which is the revenue for the patient that the hospital gets minus the variable costs. So all of you are familiar with profit, which is how much money the hospital gets to take care of the patient minus the cost, which includes the overhead and the variable costs. Contribution margin is different in that it says, all right, we've already spent all this money on overhead. If we have a case that provides enough money to cover the variable costs, then we should do that case because it contributes to the bottom line. And I think this is the reason hospitals will accept reimbursement for cases that at first glance appear quite low, because even though the reimbursement might be less than the cost if you sum variable plus overhead, even if the revenue for an additional case is only a little bit larger than the variable cost, that patient or that case will contribute to the hospital profitability. Now, it turns out that if you measure these things, contribution margin, dollars per hour of overtime, they vary significantly among patient and among surgeons. So at this hospital, if a patient was in the operating room for 2 hours, kind of a typical contribution margin would be a couple $1,000s per hour. That means that every time a patient's in the operating room, the revenue exceeds the variable cost by a couple $1,000s. Now, some of those cases are below zero, but very few, and some are quite high. As soon as you see these data, you realize that this is the reason hospitals not only are so pressured to keep the hospital full to cover all of the overhead, but they're willing to do any additional case, surgical case typically, because almost every surgical case contributes to margin, even though that individual case may not be profitable if you include revenue minus variable plus overhead. Once you realize that from the hospital's point of view, as long as they're getting revenue that is above and beyond the variable costs, which really are supplies and drugs, they're going to want to do that case. And that's why we have enormous pressure to do cases late in the day and sometimes on weekends. To finish up, when you're thinking about economics 101 in the operating room, and you're trying to figure out what to do about better cost management, you have to ask some basic questions, which is, what are the major costs of running the labor and delivery suite? And typically, it's people. In the United States, it's people. In other countries, it's other things. In countries where the cost of labor is lower, then maybe the equipment or the supplies all of a sudden become a major part of the cost. Typically in the United States, the staffing costs overwhelm other cost areas. And so really, in the 21st century in American operating rooms and hospitals, managing the staffing costs is the challenge for the OR leader. How do you get all of the work done with as few people as possible? And part of the answer to that is you have to figure out a way to match the amount of work that needs to be done with the number of people that are there to do all the work. And that's what keeps OR managers up at night, is making sure that the right number of people are there to do the right number of cases in the right operating room in a safe way. The other thing you can do is, as providers, we can do when we go to these meetings late in the afternoon, sometimes in the evening, to talk about economics, is discuss with administrators how physicians can assist to reduce overhead costs, because these are at least 3/4 of the cost. So if there's a way for you to help the IT system provide an electronic medical record that is less costly or more efficient, that will indirectly ultimately impact the cost of the care of the patient that you take care of in the operating room. And another strategy is, what are the costs in the labor and delivery suite that you can turn from a fixed cost to an overhead cost? Is there something that can be outsourced, would be one example. That way, if your hospital loses contract for a bunch of patients that you were getting, and now your volume has gone from 6,000 cases a year to 3,000 cases, if you were able to reduce the cost associated with the reduction in those patients by not having those variable costs, then that will make the financial impact of having less deliveries less significant to you in the hospital. Thank you.